Welcome to the Explainer. Today, we're diving deep into the clinical journey of liver cirrhosis. The goal here? To extract every single detail from our source PDF. We are leaving absolutely no information behind. We want all the knowledge packed right here into this Explainer so we can understand exactly how this disease alters the human body step by step. So here is our roadmap. We'll start with what liver cirrhosis actually is, then look at the causes and triggers, peek inside the liver at the pathology, explore clinical features and complications, figure out how to diagnose the damage, and finally wrap up with treatment and management. Let's get into it.
All right, Section 1. What is liver cirrhosis? Defining the disease.
The really crucial point here is understanding exactly what happens to the liver's normal, smooth architecture when cirrhosis takes over. It's basically structural sabotage. Our source defines this using three main pillars. First up, you've got hepatocyte necrosis. That's literally the death of liver cells. Second, palpable pseudonodules form, and get this, they completely lack a central vein. That is a huge problem because without that central vein, the liver's internal plumbing is ruined. It can't filter blood properly. And third, heavy fibrosis or intense scarring. Put those three together, and the liver's normal structure is totally upended. Moving right along to Section 2, the causes and triggers, looking at micro versus macro. To really wrap our heads around what triggers all this scarring, we first have to classify the physical damage by size. It's pretty straightforward, actually, splitting into two distinct camps. You've got the micronodular type, where the nodules are tiny, specifically under 3 millimeters. And then there's the macronodular type, where those nodules are larger than 3 millimeters across. Now, that size difference isn't just trivia. It tells us a lot about the root cause. Micronodular cirrhosis is driven by a very specific lineup of conditions. The data shows this spans early alcoholic and biliary cirrhosis, as well as childhood and adulthood cirrhosis. It's also kicked off by specific metabolic and genetic disorders like hemochromatosis and Wilson's disease.
On the flip side, that larger macronodular damage, the ones over 3 millimeters, well, that typically points to a disease that has really progressed. You're going to see this in the later stages of alcoholic cirrhosis or the later stages of chronic active hepatitis. It represents a much more advanced, severe restructuring of the liver tissue.
Okay, this is where the data gets incredibly specific and honestly fascinating. There's an exact, real-world threshold where daily alcohol consumption flips from bad to causing permanent damage, and it hinges entirely on biological sex and a strict 10-year timeline. For males, the danger zone is consuming more than 80 to 90 milliliters of alcohol a day for over 10 years. For females, that threshold drops to greater than 40 to 60 milliliters per day over that same 10-year span. And the source makes a very clear point to note that this irreversible damage is way more common if someone is drinking concentrated liquor.
All right, Section 3, pathology, inside the liver, examining the gross and microscopic changes.
So we know the triggers and thresholds, but what does this destruction actually look like in the body? Well, on a gross macroscopic level, the whole liver mildly enlarges. But the crazy part is its consistency. It becomes incredibly firm, literally stiff from all that heavy fibrosis. Then, if we zoom way in microscopically, the hepatocytes show fatty changes and these dying cells called Councilman bodies. We also spot those pseudolobules forming without their central veins, right alongside portal tract fibrosis and fibrous bridging between the tracts. Our source strictly terms that bridging as biostasis.
And it's not like this hepatocyte necrosis is just happening at random. It's highly organized. The cellular destruction follows irregular necrosis patterns that localize heavily in two key geographic spots, right around or near the central vein and near the portal tract. The geography of the damage is just super consistent.
Let's move to Section 4, clinical features and complications. We're talking system-wide effects now.
You have to remember the liver is the body's central filtration and metabolic hub. So when its mechanics fail, the damage absolutely doesn't stay confined to the organ itself. It sets off a whole cascade of complications everywhere. General signs include major weight loss, jaundice, and spider nevi, those little spider-like blood vessels that pop up on the chest, neck, and face. Also, since the liver normally processes hormones, its failure throws everything out of whack. In males, this severe endocrine disruption manifests as gynecomastia and testicular atrophy. It can even cascade down to the kidneys, leading to chronic renal failure. It's a total system crash.
The central nervous system takes a massive hit too. Because the liver can't clear out toxins, ammonia builds up in the blood. That causes hepatic encephalopathy, which is terrifying because it can eventually push a patient right into a coma.
Meanwhile, the liver itself swells up, a condition called hepatomegaly, which directly triggers a super dangerous localized plumbing backup known as portal hypertension. That brings us to a really important question. If that heavy fibrosis is causing this massive physical backup of blood flow in the liver, what exactly are the localized consequences of all that intense pressure? What does this portal hypertension actually do to the body? Think of it exactly like a severely blocked pipe. That backed up pressure has to go somewhere, right? So it forces fluid directly into the stomach and abdomen, creating ascites. It engorges veins, causing piles or hemorrhoids, and those incredibly dangerous esophageal varices. You'll also see prominent veins bulging around the umbilicus, known as caput medusa. Plus, it physically inflates the spleen, that's splenomegaly, and loops right back around to make that hepatic encephalopathy even worse. On to Section 5, diagnosing the damage through lab investigations. To confirm these sweeping clinical features and lock in a prognosis, which, to be clear, our data starkly notes ultimately leads to liver failure, healthcare providers have to run the numbers. Blood tests will flag a mild polymorphonuclear leukocytosis. Basically, that's a spike in specific white blood cells telling us there's systemic inflammation. Urine tests will inappropriately show protein leaking through. And because the liver is struggling to make clotting factors, the prothrombin time might increase. Interestingly enough, our source also highlights that you'll see an increased ATP level in these lab results. On top of that, the liver's overall synthetic failure causes total protein levels to just plummet, specifically albumin tanks, leading to a severe state called hypoalbuminemia. And then there's bilirubin. A normal bilirubin level is about 1 mg%, but with cirrhosis, it can shoot all the way up to between 3 and 8 mg%. That chemical spike is exactly what confirms the mild jaundice we mentioned earlier. Finally, Section 6, treatment and management. Let's look at the medical interventions. We've mapped out the strict pathology and the lab fingerprints, so what is the clinical response? Well, our source material is crystal clear here. Medical interventions cannot reverse the fibrosis, so the entire focus shifts to supportive management to handle the systemic fallout. This means giving injectable IV multivitamins and beta-complex IV fluids. And to directly fight that scary drop in albumin we saw in the labs, clinicians step in with infusions of 20% IV albumin to artificially bump those levels back up in the blood. At the end of the day, any clinical management revolves around just trying to blunt the impact of the 5 core hallmarks of this disease. To recap everything we've pulled from the text today, those are hepatocyte necrosis, the formation of pseudonodules, profound fibrosis, the resulting portal hypertension, and severe hypoalbuminemia. We've extracted every single piece of knowledge from our sources today, leaving absolutely no information behind to map out this precise, devastating timeline of cellular destruction. But seeing how irreversible this mechanical failure truly is, it leaves us with one massive lingering question. Can recognizing and acting upon that exact 10-year threshold of concentrated alcohol consumption prevent this entire systemic collapse before the very first pseudonodule even forms? It's definitely something to think about. Thanks so much for joining me for this explainer today.